Medurstand Understanding Medicine.
I'm Professor Aziz-ur-Rehman, and we are discussing various presentations of acute coronary syndrome. We have already discussed pathogenesis, the localization of RT, localization of infarction. We have covered anteroseptal infarction. We have covered anterolateral infarction. We have also covered inferior wall infarction and also posterior wall infarction. And today we're going to take up the next step, which is NSTEMI. This is a kind of infarction where there is no ST segment elevation. If you remember the algorithm of acute coronary syndrome, immediately after clinical evaluation, we do the ECG, and further steps are actually dependent on ECG. If patient has ST segment elevation, fulfilling a certain criteria, that patient is labeled as STEMI, ST segment elevation myocardial infarction. And if patient has typical history of infarction, and especially if the troponins are also positive, but the ECG does not show classical ST segment elevation, we call it NSTEMI. So this is the curriculum. We have already covered these things, and today we are going to take up this matter, NSTEMI. Right. My affiliation, I am Professor of Medicine at Rashid Latif Medical College, and I'm Senior Vice President, Pakistan Society of Internal Medicine. So this is the pathogenesis of acute coronary syndrome I highlighted earlier, but in this case, our focus will be on this variety. So there is atheroma, there is rupture, there is formation of clot, but clot is neither completely occlusive nor minimal. So it has caused very critical coronary narrowing, ending up in non-full thickness infarction. This non-full thickness infarction will not cause any ST segment elevation, because ST segment elevation occurs only if there is transmural through and through infarction. But there would be elevation of troponins because there is myocardial necrosis. This condition is called NSTEMI. The ECG changes. This is the coronary artery on the surface of the heart, and this is a penetrating vessel. It could be any vessel. It could be left anterior descending, it could be left circumflex, it could be right coronary artery, it could be posterior descending, any artery. And as per theory, in NSTEMI, we cannot exactly find out the culprit artery, because the culprit artery is identified on the basis of distribution of ST segment elevation. Since there is no ST segment elevation, so it is at least hard to identify the culprit artery, if not impossible. So this is the subcomplete occlusion, causing damage from starting from inside but not reaching the surface of the myocardium. This is non-full thickness infarction. Previously used to called subendocardial infarction, but these days we do not use these words subendocardial or subepicardial or intramural. We just use the word NSTEMI based on ECG changes. Now, this type of infarction would cause classical type of ECG changes, like because the current of injury is flowing this way, this part of the myocardium is viable and is behaving normally as per repolarization, depolarization is concerned. So there would be no ST segment elevation. ST segment elevation is caused by current of injury, and in this case, current of injury is going this way. And these are the changes. Multiple leads, all leads in that area would record ST depression and T wave inversion. Even sometimes ECG may look normal, but what is important is that there is no ST segment elevation. It is also very unlikely that ECG would be entirely normal, but theoretically that is possible. So if patient has got classical history, and especially if troponins are elevated, even normal ECG is consistent with NSTEMI. So we are now going to discuss few examples. Now this is one example. Imagine this patient with the high risks, diabetes, smoking, hypertension, obesity, or something like that, presents with severe persistent chest pain which is diffuse and it radiates to the jaw or the arm, and there is diaphoresis, and this is the ECG. Now when you analyze the rhythm is stable, no arrhythmia, no even sinus arrhythmia. There is TU inversion in limb lead 2, but we are going to analyze STT here. So as per our routine, we will scan the ECG starting from limb lead 1, limb lead 2, limb lead 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. What do you see? Do you see any problem here? This ECG is certainly not normal. But do you see any ST segment elevation? Let's scan it again. No ST segment elevation here, no here, no ST segment elevation here, not even here. I think this is slightly convex ST segment, but no elevation. So this part is isoelectric. If you draw a line at TP and PR interval, and this ST segment will fall on that line. So there is no ST segment elevation, but there is something which should attract your attention. That is this inversion of T waves. Look at these T waves. Very, very deep and symmetrical. In V1, in V2, in V3, in V4, in V5 and V6, all precordial leads and most limb leads. So look at this one, limb lead 1, TU inversion, limb lead 2, TU inversion. In limb lead 3, there is no TU inversion because the complex is predominantly downward. And AVR, again, it can be read as TU inversion because QRS complex is downward, TU inversion. So we have a patient who has presented with resting chest pain, but ECG does not show ST segment elevation anywhere. But it does show TU inversion, which is distributed in maximum number of leads and is very symmetrical. What is a symmetrical T wave? If you draw a line, for example, this is the T wave. If you draw a line in the center, two halves are more or less equal. So this kind of T wave, if it is present in multiple leads and if it is persistent, that should suggest the diagnosis of non-ST segment elevation myocardial infarction. At this stage, if you do not have troponins available, you should call it non-ST segment elevation acute coronary syndrome, because these changes are certainly reversible. Of course, ST segment elevation is also reversible. Q wave is generally not reversible, but T wave inversion is reversible. So you cannot say for sure if this is infarction unless you demonstrate that troponins are elevated, or over a period of several hours and days these changes persist. So this is in the proper context, this ECG should be interpreted as a sign of NSTEMI. What are the criteria? Persistent symmetrical T wave inversion in most leads. I don't say in all leads, but in many leads. Generally speaking, persistent T wave inversion in NSTEMI is widely distributed and is usually seen in multiple leads. And these T wave inversions are usually symmetrical and deep and present in maximum leads. And if you follow this patient for several hours, unless patient is revascularized, patient is reperfused, these changes might disappear. Otherwise, these changes persist for several, maybe days. So this is NSTEMI. What is the culprit artery? We have already mentioned it. Culprit artery we can identify based on the distribution of ST segment elevation. And in this patient, there is no ST segment elevation, so we cannot say for sure which artery is involved. I think that is the theory. Maybe experts can still find out, but mostly it is not possible. Cannot be determined. So this is the graphic form of the same thing. ECG changes would show, ECG would show ST depression and T wave inversion. This is the symmetrical T wave inversion, right? Now this is another patient. Suppose this patient, if this patient was absolutely asymptomatic, it is possible if this patient was absolutely asymptomatic and on history you know that this patient is hypertensive, this ECG could pass as left ventricular hypertrophy with ischemia or with strain pattern. But if this patient gives history of acute resting chest pain, this could also be read as NSTEMI. We are more dependent on troponins in NSTEMI than we are dependent on troponin in STEMI. So this is, I think, either persistent ischemia and STEMI or left ventricular hypertrophy with strain pattern. So the history and the troponins will be very, very helpful in this case. Same criteria. Now this is still another patient, again typical history, and if you see the ECG 1, 2, 3 AVR, AVL, AVF. So this is actually a 6-channel ECG. So you see 1, 2, 3 AVR, AVL, AVF, then V1, V2, V3, V4, V5, V6. There are actually two abnormalities. One is not related to our today's discussion, that is right bundle branch block. And because of the right bundle branch block, QRS complexes are broad and there is a specific morphology of complexes, QRS complexes here. For the time being, please forget that. But notice that there is significant ST segment depression here. ST segment depression, ST segment depression, depression. So there is significant ST depression here. So that should, I think, alert you to the possibility of acute coronary syndrome. Although you have STT depression in right ventricular hypertrophy also, but in that case, these changes should be restricted to right ventricular lead. In this case, you have this ST depression in V4, V5, V6. So this ST depression cannot be explained on the basis of right bundle branch block alone. Given the history, this patient should be treated and further investigated as NSTEMI. There is slight rhythm problem also. If you scan this rhythm, and this is a premature beat, most probably an APC, and we will have a separate module on APCs. APCs is atrial premature beat, and then we have ventricular premature beats, we have junctional premature beats. So that we will discuss sometime later. Similarly, bundle branch block we will also cover in some later module. Still another patient, chest pain. If you see the rhythm is okay, but if you see ST segment elevation, no ST segment elevation, but there is ST depression here. In the proper history, if the patient gives history of resting chest pain, with a specific phenotype of the patient, the risk factors, then I think even these subtle changes should be interpreted as STEMI. Don't ignore these changes. These type of changes may be present, I believe, in normal people, but in the proper context, in a high risk profile patient, these changes should always be interpreted with suspicion. If this patient has chest pain, I think it is mandatory to keep this patient in the hospital for a few hours for observation and to have the serial troponins, at least one troponins 5 hours after the onset of the chest pain. If that is normal, only then patient may be allowed to go home. So that was all about today's module. We covered NSTEMI. It was brief because basic concepts of infarction were covered in earlier videos. So this was about NSTEMI. I showed you a few slides. I hope the message was clear. And this is Professor Aziz-ur-Rehman from Medurstand. I really look forward to see you in my next video. Thank you very much.